Good evening, everyone, and welcome to the 25th edition of the 4D sessions. I think we've had very interesting last four sessions where we have discussed the differences between or the unique things about patients and the problems that we encounter in managing type 2 diabetes among Indian patients. So today, I think the topic is slightly different. We are looking at a very interesting topic: how patients with type 2 diabetes are different from Caucasians. Now, what these differences, and this is specifically about something that we call the Asian Indian phenotype. So, this is not just about people living in our country, but also people who have migrated to other countries. They also seem to exhibit what is very phenotypically now called the Asian Indian phenotype that we see even when they are in the West. Now, what contributes to this? Is it fetal programming? Is it the genes? Is it lifestyle? Is it circumstances? How they are different? What contributes to these differences? I think for that we have a very excellent speaker. He's Dr. Rakesh Parekh. He's from Jaipur. He runs the Diabesity Clinic in Jaipur. He's also a national executive member of the Research Society of Diabetes in India. So Dr. Parekh is very well uh, is an expert who would be able to shed us and tell us what these differences are between Indians and Caucasians. And before we start, we will listen to his small presentation before we go into the Q&A session. So Dr. Parekh, over to you.
Thank you, Professor Jacob, for such a nice introduction. And thank you, IJCP, for inviting me to speak on this important topic. So may I request someone to please put on the slides so that I can go through the slides? Yeah. So the topic that has been given to me is how Indian diabetics are different from the Caucasians, as Professor Jacob said. Next slide, please. So physiologically, our body is different from theirs, and the effect of that is that diabetes occurs at a younger age in Indian people compared to the Caucasians or Western population. So I'm sure you'll all agree with me that nowadays we are seeing more and more patients of type 2 diabetes who are coming to us at a very young age, 20, 25, and sometimes even 15, 16 years old. Kids are coming with type 2 diabetes. So the prevalence of diabetes at a younger age is increasing specifically in Indian population. Secondly, this diabetes comes in Indians not at a very high obesity or at a very high BMI. So if you compare ourselves with the Americans, they have a very huge body. Their body mass index is usually very high, and the average body mass index of Indians is not that high. We are supposed to be obese at a lower BMI compared to the Caucasians. So the cutoff of BMI for Indians is 23 as opposed to 25 for the Western population. At a lower BMI, we get the risk of all these metabolic complications. And the main reason which is probably responsible for this is the visceral obesity or the abdominal obesity. So in Indians, typically we have low body mass index, but our waist size is higher. And that is what leads to the visceral obesity and the complications of visceral obesity. Then at the comparable body mass index also, Indians are inherently predisposed to have higher insulin resistance. So we are resistant from birth itself. As Professor Jacob said, there are several hypotheses behind the reason for this. It can be genetic, and one very convincing hypothesis is of the thrift gene hypothesis. So we'll discuss about that probably in the discussion part. And then we also have early decline in the beta cell function. So Indians, when they are diagnosed diabetic, they already have lost a lot of beta cells, and the beta cell loss is further progressive, and it is faster as compared to the Western population. Next slide, please. Now, so typically to describe the Asian Indian phenotype, we are the people who are at a uniquely higher risk of cardiometabolic complications, and which can be attributable to increased visceral adiposity, higher resistance, and higher levels of inflammatory markers in our body, which lead to increased cardiorenal risk. Now, for managing such patients, we need to have a personalized approach. We need to analyze or evaluate each patient on case-to-case basis and then we need to look at the unmet needs that the patient is having, so that we can work on preventing the complications. So rather than being glucocentric about controlling the blood sugars alone, now we need to think about the interventions through which we can reduce the risk of these cardiorenal complications in our patients. Next slide, please. Now, there are several reasons for that. Genetic reason is one of them, and the second major reason for which is contributing to this higher risk of diabetes and the prevalence of diabetes, which is rising in our country, is the lifestyle change. So, in the last 2 decades, you would have all noticed that our lifestyle has changed drastically. We are getting more and more westernized. So, the kind of food that we eat nowadays is totally different from what we used to eat 2 decades back. Now the fast food is easily available, and everybody is having more and more of fast food, which is rich in carbohydrates, refined carbohydrates, and processed foods and trans fats. The packaged food consumption is also increased. And in addition to these dietary factors, there is also urbanization, which has led to the working hours, which are from morning till evening. People do not have time to go for exercise or for walk. People do not have space for doing any exercise. So because of that, on one side you have a very unhealthy diet, and on the other side you also are not having access or time for doing the physical activity, which is leading to the sedentary lifestyle. Also, there is a lot of stress, mental stress, and all this is contributing to the increased risk of diabetes in our patients. So in addition to these, the farming practices are changed nowadays. The processed food is easily available, and people are preferring to use the processed food than cooking it at home. The sweet cuisines are very popular. The social stress is there, and the perception about diabetes is lacking. So people are not very much aware about the diabetes and its complications. So these all are contributing to the increased risk of diabetes in our population. Next slide, please. Now, what are the challenges that we face in particularly in Indian population? So as we discussed earlier, the prevalence of diabetes is increasing, and it is not increasing only in urban population. Now there are several studies, specifically by Dr. Mohan's group, in which they have shown that the rise in prevalence of diabetes is equal in urban as well as rural population. Then this equal number of people, the number of prevalence of diabetic patients that we probably have around the same number of people or more than that who are having pre-diabetes, and the pre-diabetic patients are the ones who are going to develop diabetes in the near future. Then there is a very high number of undiagnosed diabetic patients. So again, in one of the epidemiological studies, it was shown that around 50% of diabetic patients, they are unaware about their diabetic status. We recently did a study which was Defeat Diabetes campaign, and in that we tested around 1 million people from India for blood sugar. And again, we also found out that around half of the patients who were diagnosed to be diabetic for the first time were unaware that they are having diabetes. So we have specific genetic and environmental risk factors which are contributing to all this. Then the diagnosis of diabetes is quite delayed in Indian population because of the lack of awareness. The prevalence is increasing in younger population. Now we are seeing more and more young people who are getting diabetes, and because they are getting diabetes at a younger age, they have to live a longer life along with diabetes, which puts them at a very high risk of getting the chronic complications of diabetes. Because of this low awareness, the delayed diagnosis, and then the healthcare facilities are also limited. So rural population, they do not have easily access to the specialist for treating diabetes. Even in urban population, people are usually treated by some quacks or some nearby pharmacies, but a lot of people do not reach a specialist diabetologist because they feel that the cost of therapy of diabetes is very high, and because of all these factors, the control of diabetes is suboptimal. The people are not treated to target their glycemic control, and which is also called as clinical inertia. And because of this delay in diagnosis, delay in treatment, improper treatment, inadequate treatment, the patients are at a very high risk of complications in the future. Next slide. Next slide, please. Yeah. So managing these diabetic patients have to be individualized in our population. We have to have a proactive approach in treating the diabetes. Often it is seen that we start the patient on a monotherapy, and then the patient doesn't come back to us for follow-up for 1 or 2 years or 3 years, and when he comes back for the follow-up, he usually has a very high HbA1c value. So this approach of targeting or treating or intensifying the therapy once the sugar levels become very high. That is not the right approach. We should be very proactive in treating diabetes. As soon as we see that the patient's HbA1c is going above target, we should keep adding therapies. And nowadays we are having very safe medicines, so it is not risky or harmful to start even a dual combination therapy at the onset of diabetes itself, so that we can treat the patients intensively and prevent the risk of micro and macrovascular complications. The therapy has to be individualized. So we have to consider the combination therapy in the early course of diabetes, because the patient may not come back to you, and sometimes you might not be able to control the patient with a single drug. Then we need to reinforce the importance of lifestyle modification to the patient in every visit when he comes back to us. Then there are multiple drug combinations which might be needed for addressing the various pathophysiological defects in diabetes. So diabetes is not a single disease. In diabetes there are around 60 different types of diabetes based on the etiology of diabetes. Among those, type 2 diabetes is the most common, which we are talking about right now. But even in type 2 diabetes, there are several defects. So there were earlier only two defects which were identified, that was insulin resistance and insulin deficiency. But later on, we realized that there are at least 8 to 12 different pathophysiological defects in a type 2 diabetic patient. And one patient might be having a combination of these defects in different proportions. So we need to individualize the therapy based on these different defects, and we need to find out drugs which can address these different pathophysiological defects. Now we have newer drugs like the DPP4 inhibitors and SGLT2 inhibitors. These are not anymore new drugs. They are introduced more than a decade back, but now these drugs are off patent. So earlier these drugs were priced at a very exorbitant price, which was not very easily accessible to most of the people. But now, because the drugs are off patent, they are available at a very affordable price, and they're also available as a fixed dose combination. So we can make use of these newer class of drugs which have multiple effects on different pathophysiological defects in type 2 diabetes. Next slide, please. So talking specifically about this combination, these SGLT2 inhibitor and DP4 inhibitor, they are now available as a fixed dose combination in a single pill. So both of these drugs have a modest effect on glycemic control, and when you combine them both, you get a very good glycemic efficacy. Among these, the SGLT2 inhibitors are known to reduce the body weight, and DP4 inhibitors are weight neutral. So when you are using this combination, you will expect some weight loss in the patient. There is no risk of hypoglycemia. Virtually, there is no risk of hypoglycemia in this combination. Moreover, the SGLT2 inhibitor, they have a possibility of some genital or urinary infection in some 5 to 6% of patients. But when you combine these two as a fixed dose combination, somehow you see that the risk of these UTIs and genital infections is also very less. So these are the very safe and cost-effective drugs which are available now with us, and these are a very good partner to be added to metformin in the management of these patients. They improve the metabolic profile of patient by addressing different pathophysiological defects, and these are preferred in the patients who are at a higher risk of cardiovascular events or kidney diseases, but you can definitely give it in every patient. The initial combination of this therapy is considered in patients who are presenting with a HbA1c of 1.5% above the target range. So even if a patient has got HbA1c of 8.5, if you use this combination, you can expect the drop of A1c by 1.5%, so that you can bring down the patient to the target level. And these, as I said earlier, these are the drug of choice for the patient. This SGLT2 inhibitors specifically are the drug of choice in patients who are at a high risk of CV events or kidney problems. Next slide, please. So this unique combination is a suitable option for Indian patients who are type 2 diabetic patients, because it's very safe. It has got a rapid onset of action. The glycemic control is sustained. It improves both insulin resistance as well as beta cell dysfunction. It helps in reducing the body weight and blood pressure. These are the extra glycemic effects of these drugs. It reduces the pill burden by combining the two tablets in one. Overall, it's very cost effective and very safe combination. So I think now we can start the discussion, Professor Jacob.
Yeah, thank you. Thank you, Dr. Parekh, for that very interesting talk. So I'll start with the first question. My first question relates to what you were discussing about the prevalence of diabetes, both in urban and rural areas, have become quite significantly high,
Yeah.
much more than what data from Western countries show.
Right.
One of the reasons could be, you very clearly pointed out that our patients develop diabetes at a younger age, probably about 10 to 15 years earlier than Caucasian patient. That could be
Right.
one reason. But what do you think is the major factor why the prevalence is so much higher in our country compared to Western countries?
Yeah. So as we discussed earlier, we have that typical phenotype which puts us genetically at a higher risk of getting diabetes. And but this was there earlier also. So the question is very appropriate, that why the sudden rise in prevalence. So now I think that the environmental factors are playing a big role, because in the last 2 decades, as you and me would both have seen that generation where our lifestyle was totally different. We were quite active. We were using bicycles, we were going for walks, we had time to play, we had space to play. And that physical activity is totally gone now because of this total westernization. Now our children play only on the mobiles. They play the video games and on TV and mobile, and you hardly find a child going for outdoor games. Secondly, the mental stress. Now people who are in job, we know that how their job profile is. They are busy from the morning till the late evening, and even when they come back at home, they are very stressed. Then diet, the lifestyle has changed so much that we usually prefer to go out for eating rather than having the home cooked food. And whatever we are having even at home, most of that is cooked by using some processed food. So the food is unhealthy on one side, and the sedentary lifestyle is adding to that, the mental stress is adding to that, and all that is leading to the high prevalence of diabetes. One more factor that I find specifically responsible for, as you said, that now we are seeing diabetes in younger population. I do see children at the age of 15 to 25 who are coming with type 2 diabetes. They are not typical type 1, they just come like a type 2. And usually in such patients, I find that they have a family history of diabetes in both their parents. So now, because of the rising prevalence of diabetes, you will often see that husband wife both coming together, both having diabetes. Now their children definitely are at a very high risk of getting diabetes, and at a younger age.
So, if I have to summarize, I think we were already genetically predisposed, maybe genetic or epigenetic, but we had a predisposition. And now, in the last couple of decades, the change in lifestyle has made this epidemic, or what you call an explosion of diabetes,
Right.
both in our community and in our clinic. So, thank you. Next question we discussed. I mean, you gave us those four markers of what we call the Asian Indian phenotype. One was they were getting diabetes at a younger age. Two, they were getting diabetes at much lower BMIs than Caucasians.
Right.
Third, you said they had a lot of inflammation
Yes.
going on. Many of them had early complications. Many of them had more insulin resistance, poorer beta cell function. Now, this phenotype is what you see in your clinics.
Yeah.
So how do you approach this phenotype, and how is this disease, how will you characterize this disease when you see such a patient in your clinic for the
Yeah.
first time?
So see, around 2 3 decades back, I guess there was a nomenclature for this phenotype that was called as metabolic syndrome. Nowadays, we don't talk about that very often, but I had a lot of interest in metabolic syndrome, and I did a lot of research on that particular front as well. So basically, the key conspirator behind this whole cascade of abnormalities is the visceral obesity. So, as we discussed earlier, the Indians have a very high amount of fat in their tummy or in the abdomen. Now, the blood from that visceral compartment that goes to the liver through the portal circulation. It doesn't enter the systemic circulation directly, and that is why the metabolites from that particular visceral abdomen, they go to the visceral compartment, that they go to the liver, and the liver is exposed to all these toxins, and which leads to the resistance. Now, how do we identify such patients in the clinic? A very simple tool that I would like to emphasize upon here, which was based on the research that we did earlier, is index of central obesity. Now it's very easy to calculate. Index of central obesity is basically the ratio of your waist size and your height. So most of us do know what is our waist size. It's either 32 inches or 34 inches or 36 inches, like that. And we also know our height in the feet and inches. So if your waist size is more than half of your height, you are basically centrally obese, and you are someone who should be investigated further for your blood pressure, for your HDL, triglycerides, and fasting plasma glucose. And if you do these four parameters, you can identify if three of these five parameters are abnormal, then you are a person with metabolic syndrome. Even if your blood glucose levels are normal or pre-diabetic right now, you are at a high risk of getting diabetes in the future. So I think this is how we can easily pick up such patients in the community as well, not just in the clinics.
So I think that was a very relevant point you made. I think most of us, I know that what my height is in inch because most of
Yeah,
us remember our heights in inches because that is the nomenclature we follow in our country. We
right.
all know our waist circumference because we have to buy trousers and we do know. So I think it's
Right.
a very simple way of figuring out whether you are
Yeah,
abdominally obese. So I think that's an excellent point you are making. And we also know that many of this explosion has come because of poor lifestyle in the last few decades. Now, this kind of patients, you have identified him, you have seen that he has the Asian Indian phenotype. What is your instruction or what is your advice regarding lifestyle? You ask him to reduce his stress at office, he'll say, my boss will give me more stress.
True. Yeah, so see, it's really a very challenging task, for basically for the middle-aged working people. Now, those are the people where it's very difficult to convince them for any kind of lifestyle change. As you rightly said, the mental stress, we cannot bring down that stress just by talking to them. Probably we just need to tell them to develop a habit of going for some kind of a yoga or meditation on a regular basis. So even if that person starts doing the yoga or meditation for just 10 minutes a day, that will definitely help him in reducing that mental stress. Second thing is to convince them to find time for exercise, because they would all tell you that I have to get up early in the morning, then I have to pick up that cab or take the metro and go to the office, and then I come back at the night and I have dinner and then I go to sleep. So somehow we need to find some time somewhere. At least you can find the time in slots as well. It's not necessary that you should go for a brisk walk for 45 minutes continuously. You can tell them that it doesn't need to be done at a stretch. You can do it in three compartments. You can do a 15 minutes walk in the morning, 10 minutes in the afternoon, 15 minutes in the evening. Somehow you can keep yourself physically active. Moreover, when you are working in the office also, rather than sitting on the table or the bench for the whole working hours, you can try to make it a habit that you keep moving in between. So if you can walk around while working, that will also help in keeping you physically active. So this is what we can advise to the minimum to these people. The other people who are not having such a tight schedule, they can definitely be advised to find out time for brisk walk, to go for a brisk walk for 45 minutes a day, to do some additional aerobic exercises or yoga or meditation, and also to focus on their diet. We should explain them that the in the diet, it's very difficult to have compliance with diet. A patient would follow your dietary advice for 1 week or 2 weeks, and once the sugars are controlled, then he will again lose the control. So to those people, we need, basically I would explain them that rather than following a chart which is very difficult to follow, you should at least know what is good for me and what is bad for me. So in the breakfast, if you have an option of going for a sandwich and an omelette, so omelette or egg is better for you than a sandwich. If you have an option of poha or sprouts, the sprouts are better than poha for you. So if we explain them that the things which are rich in carbohydrates, proteins, or fibers, they are better for you than having something which is rich in carbohydrates. So that way, if we give them little liberty, that helps in being little compliant with our lifestyle advice.
So I think you have been very clear about lifestyle. Now, the next question I'm going to ask you is something that I've asked all the other panelists before. And I think if you can put it as 3 points, what are the three major challenges that you face in your clinic when dealing with patients with type 2 diabetes?
So the first challenge is to convince the patient that diabetes is not blood sugar alone. The patients, they come to you with a sugar report and they feel that if you can bring down the sugars from 200 fasting to 100 fasting, my job is done. So I need to tell them that is the challenging task, that even if your sugar levels are controlled, diabetes is there, and which is responsible for long-term complications. To educate the patients about the need for a regular intensive therapy and targeted at prevention of complications is one thing, because that is something which they don't see immediately. If I tell them that I am working on reducing the risk of your cardiac events or renal events after 15 years, which might develop after 15 years, they would not appreciate that. They just want something which can happen immediately. So first thing is that. The second thing is particularly for the patients who come to you with that prejudice that the allopathic medicines are harmful. So they would want some other solution. They would say, just don't give me tablets. Ask me anything, I'll do that. Ask me, give me some Ayurveda preparation, some herbal preparation, or some miracle cure that can cure my diabetes. So it is very challenging to convince them that these terms like cure or reversal or remission of diabetes, these are just misleading. Basically, diabetes, I would call it as a process of aging. You cannot reverse back in the aging process. Maybe that you can control your diabetes without medicines for a period of months or years, but that doesn't mean that you are non-diabetic. You still need to be very careful and keep monitoring yourself so that you don't progress towards the complications. So these are the two things which are very challenging in a normal condition. And the third challenge that we often face is the patient who requires insulin but is not willing for insulin. Those are the patients who typically come to people like us because we are diabetes specialists, expecting that I have been told insulin by everybody, but I came to you only for this reason that you will save me from insulin. They feel that we can do something by which they don't require or they won't require insulin. Now there are so many myths surrounding insulin. So in those patients, to convince them and explain them that this insulin is the right treatment for you at this stage is actually challenging. Some people just do not do it at all despite you trying your best. So in those patients, I insist upon giving the first injection to the patient myself, or in front of me I ask the patient to take the injection. Then only the patients, the fear that they have, the phobia of the needle that they have, can be addressed, and then some of these patients do take the insulin also. So yeah, there are challenges, but if you give enough of time for every patient, you can handle those challenges.
So if I have to summarize, I think I can summarize it as two challenges. One, they do not have the right information.
Right.
That means they need to be educated about everything, from why everything is important, why long-term complication. And the second I can see is they have information which is wrong information. They have in their head
right,
medications are wrong. There is some cure available from some Baba can cure it some way. So they have wrong information and they have lack of the appropriate information. And I think you made it very clear that as physicians, our job is to remove some of the misconceptions that they have and give them the right kind of information. So thank you very much for that. Now, again, something that you talked about as one of the ways you wanted to address treatment was to have early combination therapies. And you said that anybody who just, let's say, presents with an HbA1c of 8.5%, you would prefer them to be on not one drug, as we would have previously, maybe 10 years back, we would have just put them on lifestyle and metformin, seen how they respond, and then decided on the second drug. But right. You suggested that anybody who's 1.5% above the target for HbA1c should be put on combination therapy. So now I want to ask you, what are your favorite combination therapy? Now, just imagine this is a patient who has come for the first time with diabetes. What are your favorite combinations? And do you sometimes even prefer 3 drug combinations?
Yeah. So see, first of all, let me explain why I want to start dual or triple drug combination at the onset. So the reason behind that is there has been a recent study which has shown that the glycemic control in the first year of diagnosis itself is the decisive factor. So if your control in the first year itself is poor, that leads to the very high risk of complications in the future, as was seen from the legacy effect that we saw from the Wikipedia study. Again, there was another study which just highlighted on the importance of control in the first year itself. So we do not have time nowadays. Like, earlier we used to give them 3 months for only lifestyle, then 3 months for metformin. So rather than wasting that much of time, we should start intensive therapy at the outset itself and bring down the HbA1c to below 6.5 in younger population as soon as possible. The second reason is that earlier we just had metformin and the sulfonylureas. So metformin definitely was a good drug, but to add sulfonylurea, you had to keep in mind the risk of hypoglycemias. So you were not very sure if I should give the patient the combination at the outset or not. But now you have so many safe drugs which do not have any risk of hypoglycemia. So there is no harm in adding 2 or 3 drugs among the newer drugs at the outset when the patient is diagnosed as diabetic. And the third reason is that now we know that diabetes is not having only those 2 defects, insulin resistance and insulin deficiency, but there are multiple defects. And we need to use these newer drugs which are addressing those different components. So that is the reason, that is the logic behind using combination therapy at the outset. Now, among these, the metformin remains the gold standard. And on metformin, these 2 drugs that are available with us, one is SGLT2 inhibitor and the third is DP4 inhibitors. Both of these drugs are very good. They both are weight neutral. Rather, SGLT2 inhibitors can give you weight loss. They are not having any risk of hypoglycemia. Their long-term CV safety has been established. And among the two, SGLT2 inhibitors are the drugs which are now seen as a miracle drug, because they are now being used by the cardiologist, by the nephrologist. They have the effects beyond glycemic control. They reduce the risk of cardiac events. They reduce the risk of hospitalization for heart failure. They reduce the risk of progression of CKD. So with all these beneficial effects, the SGLT2 inhibitors become the second drug of choice for me. And the third drug definitely is a DIP4 inhibitor. So that is the sequence, but only in cases where the patient is not, appropriate patient for SGLT2 inhibitor, like someone who is a very elderly, frail patient, or a patient who is insulinopenic. Now, in those patients, I might probably avoid that drug, but otherwise, most of the patients are suitable for this combination.
All right, Dr. Parekh. So last couple of questions. Now, I think you did discuss about this combination of SGLT2 and DPP4. You said that initially your combination might be metformin with a DPP4 or metformin with SGLT2 inhibitor. Subsequently, or you may have a patient who has been on metformin. Then when you're adding the second drug, you might consider SGLT2 and DPP4. What is your opinion on this particular combination of SGLT2 inhibitor and DPP4 inhibitor?
Yeah, the fixed dose combination of the two. So yeah, that's a very good combination. Reason, as I said earlier, they both complement to each other. So they both are acting on different, pathophysiological defects, and they, along with metformin, cover all the defects in the type 2 diabetic patients with pathophysiology. So that is the reason for this. And then secondly, when you use them as a fixed dose combination, there are some studies which have shown that the risk of genital infections also goes down. So when I'm putting a patient on a SGLT2 inhibitor, I am concerned about the risk of genital infections, though it is just 5 to 6%. But then when I'm using this combination pill, that risk is further reduced. So that is what gives me a confidence, and that is why this pill becomes a favorite combination pill in addition to metformin. Now we even have triple the combination with all these three.
Yes, so I think that is what. So the final question I have for you is this: I think you have huge number of choices now with SGLT2 and DPP4. There were the expensive choices earlier, and now we have plenty of choices, even with generic preparation, with vildagliptin, with sitagliptin, and dapagliflozin. So we have a lot of permutations and combinations available at almost all cost points. So which now, once again, the last question I have is, what is the cohort of patients that you would put this combination, or is there a cohort? Anyone with the Asian Indian phenotype you might consider this combination?
Yeah, so if we go by the guidelines say that the SGLT inhibitors should be the first drug. Now, even before metformin, some guidelines say so, in patients who are at a high risk of atherosclerotic cardiovascular disease or at a high risk of CKD. So in those patients, this drug definitely becomes the drug of choice. In addition, because of its weight loss effect, even if a patient is not at high risk of all this, I would use this drug because it definitely gives a very good weight loss, and patients feel very happy once they lose weight. Some patients even go in remission. The newly diagnosed patients, if they lose 10, 12 kgs, along with their lifestyle measures, they even go in remission. So definitely for those people in whom it is indicated, we should use it. For the patients who are overweight, we must use it. And moreover, there is no harm in using it in anybody. So anybody who is a type 2 diabetic patient, unless he has got some contraindication for this combination or for any of these drugs, I think we can use it for every type 2 diabetic patient.
Exactly. So thank you once again. I think what is very clear is in the Western literature, they might have some concerns with costs, and
Right.
because these drugs are expensive there. But in India, we should not really have concern, because we have more than enough generic preparations available of this combination. So I think we've had a very good discussion. We are now, I think, a little beyond 30 minutes. So I think I'll thank you here for your excellent presentation and for telling us all the differences between not just the physiology between Indian and Caucasian patients, but also how we treat these patients are also different. We use a lot of combination. I think good thing is fixed dose combination was something that we did in India and was looked down upon.
Right.
And now I think
Right.
even Western countries, they have
Yeah.
drug combination, which they would have never thought of as scientific. Let's say 10 years back, they would say, why are you using 3 drugs
True.
in a single pill? So now they have come back to that. So thank you very much. And
Thank you.
thank you. And